So, my name is Tom Hughes. In this part of the lecture I'm going to talk about why it's difficult to make diagnoses. I think making diagnoses when there's a time pressure is really difficult. And only those who've tried to do it, particularly those who've tried then to give a dangerous treatment, know how exquisitely difficult it is to be really confident. Recently, the idea of mimics and chameleons has taken off. I've challenged the people who've promoted this by pointing out that not very long ago, both mimics and chameleons were called the wrong diagnosis. But now we are transferring responsibility somehow to the patient by saying, oh, you're a mimic or you're a chameleon. I think the barristers would say it's an abrogation of responsibility, transferring the responsibility from the clinician to the patient. But we'll use that term, and stroke chameleons I think are particularly tricky. So by this I mean that when you get to the bedside you think to yourself, this can't be a stroke, and yet it is. Obviously the whole thing is predicated on what you're thinking before you see the patient, and therein lies a lot of the error. But here we go. So I'm going to suggest that there are some things that create problems for us, which you as registrars will be only too aware of, but I think there is a place for making these things explicit and combing straight your own thoughts. I think the process is a problem, and I think the pathology creates its problems. I think the process to which these patients are necessarily, by the way, subjected in the first few hours lends itself to people being mislabelled. I don't think anyone disagrees with that. If we think about sensitivity and specificity of tests, we want the test to have sensitivity. We accept by it having high sensitivity that we will pick up lots of false positives, but at least we'll capture those who've had the event. Then I think there are things to do with the pathology of stroke, generic issues, and those related to the donor vessel and the recipient vessel that make it difficult for us. If any of you don't use this terminology, the donor vessel is what it says it is, the vessel that donates an embolus. Heart, aorta, great vessels. The recipient vessel is the vessel at which the embolus stops. And it's a matter of size, really. Just once the clot gets to a vessel it can't get through, it blocks it. Some of you, I hope it's only one or two, may not have read Thinking Fast and Slow by Daniel Kahneman. Christmas is on the way. Parents need things to buy you for your stockings. It's a book that I've read once, I'm now reading it again, and I've realised that to get the most out of it you have to, I think, read one chapter, then spend a week practising what he's preaching. Then do chapter 2, spend another week. He's talking about things like priming, where you get to the bedside and someone said to you, oh, it's another stroke, oh, he's diabetic hypertensive. By the time you get there, your brain is stroke. You've been primed. Or you've been anchored for other reasons in that diagnosis. Availability problems, where the thing you saw yesterday present with the Horner syndrome was disease X. You see another one today, and that's the first disease you think of. It's stuff we go round and round with all our medical lives, but he's managed to capture a lot of it in this book. I can't go into detail about that, but the whole business of what we are thinking when we approach the patient is worthy of a lecture in itself. So, what's all the fuss about? I think you can be a roundhead or a cavalier when it comes to acute stroke. I think it is worth pointing out that it can be easily construed as a perfect clinical storm. We've got a health service not used to dealing with it as an emergency. There's no pain. What a tragedy for stroke patients. Give or take the odd dissection, etc., and some intracerebral hemorrhage. As a rule of thumb, compared to myocardial infarction, etc., stroke is relatively painless. And there's relatively little drama. Posterior circulation, I grant you. Thalamic stuff, I grant you. But lots of the anterior circulation stuff, patients are just devoid. They're marooned, they're bereft. And there's no pain, usually. So they don't auto-triage in casualty. If you go into casualty and you say, I've got chest pain, the health service forms itself around you. Leads will be on your chest before you've got your shirt on. You'll be there on a trolley with lots of people making a fuss of you. You go in there and say, can't quite find the words and my language. They'll put you in the corner whilst your brain, left hemisphere, turns to porridge. So everything militates against stroke being diagnosed quickly. If that wasn't bad enough, I think patients have difficulty telling their story because they haven't worked out what's wrong with them yet, and the clinical signs are immature. As a rule of thumb, acute MCA occlusion, you don't get obvious spasticity, you don't get obvious brisk reflexes. I think you do get an upgoing toe in the first couple of hours, but you can often get to the bedside and not be sure whether it's upper or lower motor neuron. Then to boot, the CT scan is often an excludogram. It's making sure it's not blood, it's not tumour, it's not abscess. So I think it's very tricky. The other view is that it's all a storm in a TPA cup. Sorry, that's a terrible gag, I'll get rid of it. Come on, it's common, you know. It's pretty straightforward, isn't it? You know, there aren't many things that make you go from normal to abnormal. And it's all protocols, isn't it? All you've got to do is follow the protocol. And it's just scales, work out the NIHSS and all the rest of it, and you're home, tickety-boo. It's like painting by numbers. And I think it is fair to say that there are only, he said, three big pathologies that we see day to day. If you look in the Oxford Textbook of Medicine, I always remember seeing the massive page of causes of cerebrovascular disease. Actually, in practice, we see large artery occlusion, and that is usually due to a proximal embolic source. Aorta, heart, great vessels. That is usually proximal embolic source. You might have a dissection that's causing mischief, but that is usually a clot from a big source. That causes large artery infarcts and gives you this wedge-shaped thing that involves cortex and subcortical white matter. That does lend itself to a formulaic approach. The thinking, I can say with some confidence that that person, because their anterior cerebral artery is spared and their posterior cerebral artery is spared, I can, without being bullshit, predict that he will have a left hemiparesis, that his face and arm worse than left. He'll have some variant of delusional misidentification. He'll think his arm is a snake, or he'll think his arm isn't his, and that will last a few days, and then he'll be left with this awful neglect, and then he'll eat only what's on one half of his plate. In his mind's eye, he won't see the left side of any room, and he'll be left with that probably in some form for the rest of his life. His language, to state the obvious, will be normal because his left hemisphere is normal. So the quintessence of his personality will be preserved. He'll be able to do his own shopping online, banking, etc. But he won't be able to drive, probably because his inattention will be too bad. Obviously, lots of exceptions. Similarly, when we come to lacunes, just to state what is pretty well received wisdom, I think, lacunes are due to occlusion of lenticular striate perforators, which are end arteries that come off the proximal, middle and anterior cerebral. They supply deep white matter. They do not supply cortex. I repeat, they do not supply cortex. So really, a lacume is something you only get in the deep white matter, and I should add the deep grey matter, by which I mean caudate basal ganglia. Grey matter is cell bodies, two types of grey matter, superficial, which is cortex, deep, which is the deep nuclei, and white matter is axons. So these lenticular striate perforators supply the deep grey matter and the deep white matter. And when they occlude, they cause a small infarct, and that is called a lacune, a hole. And you can have these lacunes and get away with it, depending on where the lacune is. If you have a lacune in a strategically important position, particularly the internal capsule, where all the motor fibres are compact for the first time, you can have a devastating hemiparesis. Without cortical involvement, because your cortex is supplied by the big arteries to the top. These little perforators get your internal capsule, and if they do get it, you can have a terrible infarct. So I remember being told off once on a general medical ward round. The diabetologist I was working for, I made the mistake of saying to him, this man has mild diabetes. Well, you would have thought I'd sworn on the ward round. He said, there is no such thing as mild diabetes, lad. And of course he's right. Type 2 diabetes mellitus can cause havoc. We could use the same sort of thinking for small vessel disease. There is a sort of feeling I get that small vessel disease is, it's only the small vessels. But if those small vessels are supplying things like the internal capsule, then the person can be left with a devastating problem. It's worth pointing out that whilst that is usually an embolus, these can be embolic, because anywhere blood goes, clots can go, but there may be other pathologies operating here, causing in situ obliteration of the lumen of these vessels, usually patients who are hypertensive, and it could be that it's not only their hypertension, but it's their cranked up renin-angiotensin system that is producing powerful vasoconstrictors that have a direct effect on these little incy-wincy arteries, as I call them. And you end up with these dot, 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 and if you get a dot there, somewhere near your internal capsule, that's when you're in trouble. Obviously, if you get enough of these dots, you cross a threshold where suddenly you've got a gate apraxia and you've got a subcortical dementia. The third type, and it's common for us to see all these three types in the same patient, is what is now called leukaryosis. Used to be called Binswanger's disease, periventricular lucencies, etc. That's part of normal ageing, more common in diabetic hypertensives, more common in some degenerative diseases like Alzheimer's. And it's thought to be the very ends of the big arteries. They give off these tiny little arteries called electromeningeal perforators to supply this periventricular white matter. They are the patients who have a gate apraxia and a subcortical dementia. And those, I think, are the three main types. So, only three pathologies I'm suggesting. Mind you, having said that, pretty complex, but only three. But I would suggest that these protocols risk protocolizing our thinking. And there's a lot of lazy labelling going on, and I've been guilty of it. But underneath there are some real concerns. The one that's really got me recently is that when we say something is a stroke, but it isn't, whilst that stroke label sticks to them, there may be something 10 times more treatable that they've got that we're missing. And the most extraordinary thing recently was herpes simplex encephalitis, where it was labelled as stroke, we were about to thrombolyse it, and then we said, hang on, this story's not right. Herpes simplex, give them acyclovir, complete recovery. What would have happened if we'd given them TPA, sent them to the ward, they were on the pathway, goodbye, you're on the pathway, goodbye, and then we would have had to rescue them. But, yeah. That said, I think protocols save lives, and if we protocolise the process and the care pathway, but we somehow preserve our thinking, then that's a beautiful marriage. So my catchphrase for this is tick inside the box and then think outside it. Satisfy the bits of the protocol, get them to the right ward, make sure that they're not dehydrated, their skin, their feeding, all of that. Tick those boxes, but continually think outside the box and think, I wonder what this could be. Is there anything else we should be thinking of? And that's a marriage, I think. It's a Barack Obama thing. You've got a bridge. There's pointless staying in your own silo. So tick the box and make it a really happy tick, and then think outside it. I mentioned roundhead or cavalier. Thrombolysis does really bring out the extremes of your attitudes. So this patient made me cavalier. I went to casualty. It was almost the highlight of my career. I was completely by myself. This patient was unconscious, she was 89, and when I woke her up, I managed to examine her well enough to say that she had a hemianopia, but she also had a dysphasia, and I couldn't wake her up. And I said, the only thing this can be is posterior circulation ischemia, giving her an occipital lobe lesion and a thalamic lesion. I thought the thalamic lesion must be on the right, because I couldn't imagine how she could have right and left. In the end, it was right and left, and because the thalamic supply is so varied, there are ways that you can get this. But we put her in the trial, the international stroke trial. She was thrombolised, as you can see. It didn't cause any benefit to her infarcts, but she survived. But we made the diagnosis, and we were right. But like everything, the minute that you think you're getting good at medicine, you can guarantee that waiting for you around the corner is your next bit of humble pie. And this was a patient who had this condition, cerebral amyloid angiopathy. They were in the trial. They presented with relatively trivial, in hindsight, sensory problems. I gave them TPA, and this patient bled everywhere. And for those of you not familiar with this, fragile, congophilic vessels, feature of normal aging, nothing to do with amyloidosis. It's nothing to do with systemic amyloidosis. This is a cerebral amyloid angiopathy. There are inflammatory variants of it, but it's a common cause of lobar hemorrhage, and it commonly presents, and this is hot off the press, with this thing called amyloid spells, where they typically have sensory involvement of their face, their hand, their foot. It can involve the whole side. It lasts for 15 to 20 minutes, and then it starts to improve. And if you hear that story, don't thrombolise them, like I did. So, what's a stroke chameleon? It's when it doesn't look like a stroke, but it is. What is it about the process that makes it difficult? If we look now at why the process might catch us all out, and I speak as someone who's been caught out by everything, what is it about the process that makes it difficult for us to make the diagnosis? And just to remind those who've just arrived, a stroke chameleon is something that doesn't look like a stroke, doesn't feel like a stroke, but is. What is it about the process that can lead to mistakes? Well, time's in short supply, and I think that's a big factor. The assessment tools we use are relatively crude. And I think anything that creates a number, like the NHSS or the ABCD2, should be very much towards the end of your consultation as an adjunct after you've made your diagnosis. So for instance, if someone comes in because they've got a positive fast test, you get lots of mimics with positive fast tests, but lots of people who have a negative fast test will have a devastating stroke. So these are relatively crude tests. The simplest thing to remember is that you can have a dense hemianopia, lose your driving licence, lose your job, and your fast test will be negative. So remember that these tools are crude. And all of these tests, positive or negative, I'm repeating myself, have a priming effect on us. However difficult it is, if someone walks into my clinic room and says, this 69-year-old diabetic hypertensive with one black foot, chest pain climbing hills, who's had angioplasties to both his femoral arteries, presented with the idea that I'm going to say it's not a stroke, it can't be vascular, it's really tricky. Whereas if they present to me the story of the event without the previous convictions, I find that easier now. Although when I come up with a differential, I will rank the differential according to the population they come from and what's happened to them before. But if I know what their previous convictions are before I see them, I find it very difficult to think outside the box that's been created for me. That's called priming. And remember, NIHSS is pseudo-quantification. Just because the NIHSS is 26 doesn't mean it's more likely to be a stroke. It's a grading scale that's pseudo-arithmetic that you use after you've made your diagnosis. Some thoughts about the pathology. These are generic thoughts. I think the fact that the story is usually, when you're seeing them, is just starting to evolve, the patient may not have worked out what it is they can't do, or they may have lost the ability to tell you. This business of it usually being negative is a trouble. And I usually tell at this point, without any fear of you knowing who it was, an eminent professor from South Wales, who I know Dr. Shetty would know, woke up at night, wanted to go to the loo, woke up at night, realised he had vertigo, wanted to go to the loo. He crawled to the loo, went to the loo, and as he was going to the loo, he realised he could only see one half of the bathroom. And he was doing his own visual field tests. He realised he was hemianopic, the world was spinning round. He added it up to a posterior circulation event. He then crawled back to the bedroom, but he didn't make it. And he lay on the landing carpet. His wife shouted, "What can I do for you, darling?" He said, "Get me a quilt, I'll be fine in the morning." She covered him with a quilt on the landing of their house. He went back to sleep, intermittently waking up. Next morning, came to hospital, dense hemianopia, massive posterior cerebral artery infarct. No pain though. If that had been painful, there would have been an ambulance at that house straight away. He would have been in before we could have said anything. But the lack of pain, people say these things like, "Oh, I didn't realise what it was." I thought I'd slept on it. I took 2 paracetamol. I thought it was something I'd eaten. It's a real menace. Signs. This is my current table of signs for teaching the SpRs in neurology. And I think there are 3 stages of signs. And I'd be interested in your comments about this. First few hours, 24, 48, they're immature. And it's a particular problem with central nervous system disease. People are usually not hypertonic. They don't usually have brisk reflexes, certainly in the first 6 to 12 hours. Classic example is spinal cord compression, they're flaccid. Areflexic, I've seen areflexia with acute cord compression. Don't say that outside this room. I've seen people diagnosed and treated for Guillain-Barré syndrome with spinal cord compression. Immunoglobulin 5 days hasn't worked. Spinal cord compression. And I understand, in casualty, these signs are not there. You don't get upper motor neuron signs consistently, acutely. Day 2, 3, 4, the WRVS ladies can elicit these signs. The tone, the brisk reflexes, it's all there. It's a full house, it's a party, it's a carnival of signs. 3 to 6 months later, on the stroke rehab unit or the neuro rehab unit, you then have musculoskeletal complications. If you think about a simple arm, day 1 it's flaccid. Day 3 it's hypertonic. Week 3 it's here. Month 3 you've got an ulnar nerve compression because of your persistent elbow flexion, which is giving you an ulnar nerve palsy. And if your wrist flexion is bad enough, you get a median nerve palsy, so you get a wasted hand. Musculoskeletal, neurological, neurological, musculoskeletal. It's a cascade. And I think most of the complications that make examining people on a neuro rehab unit or a stroke rehab unit 3 to 6 months down the line are musculoskeletal. Pain, obviously, is another one. If people are in pain, very difficult to examine them. And then I think there are 4 types of sign. Signs you can just see from the end of the trolley. Signs you can elicit even if they're not cooperative, like reflexes, as long as they're not moving around. Signs that they've got to do something to help you. Strength, finger nose. And then signs that require sit-down cooperation, like neuropsychology. And everything is against us when it comes to acute stroke, because they're immature, and I think the ones we can get at tend to be the ones we can see and the ones we can get without cooperation. Trying to get someone with an acute posterior circulation stroke to cooperate with you, very difficult. And for any of you poetry fans, we talk about the R.S. Thomas sign. R.S. Thomas, slightly unusual, eccentric Welsh poet. We talked about one of his friends dying and said that he was stranded upon the vast and lonely shore of his bleak bed. One of the features of stroke that I look for is this sense of loss around the bed. If there's too much drama, if the monitor's beeping too much, if there's temperature, if there's stiff neck, if there's any drama, spots, screaming, I think, no, there's something else going on here. just as a sort of starter for 10. Finally, what about the donor vessel and the recipient vessel? Let's do 3 cases to illustrate my points about the donor vessel, for those of you who are a bit late. The donor vessel is the vessel that donates the embolus. Heart, aorta, great vessels. That's the donor vessel. The recipient vessel is where it stops. So, have a go at this. 53, neck pain. Immediately, he's RS Thomas negative. There's pain. Something funny going on here. So on the phone I'd be thinking, well, either this is a dissection or it's something else. Neck pain, dissection, cervical disc, infected process in the neck, root disease. But, as you'll see, you do get dissections. Then he's got this delay and then something else happens. Typical, actually, I've already told you what this is, but dissection, usually you get this pain, then a delay, and then the dissection donates an embolus or occludes the vessel hours to days later. You see rugby players, terrible to say this at the time when that's happened, but the rugby players I've seen with dissections, they tackle, or whatever it is, they know they've had a wallop, then days later they have their infarct when it donates an embolus. And when we saw this guy, he sort of had this impossible constellation of signs. We couldn't wake him up. He had a vertical gaze palsy, marked left-sided limb ataxia, proximal left arm weakness, and distal left arm power. So the reason I use this case is for chameleons is, as a rule of thumb, you shouldn't be drowsy at onset with a stroke. Left MCA occlusion, big left hemisphere infarct. Day 2 or 3 you're drowsy, not at onset. The only exception, and there's always an exception, is thalamic infarcts, or massive pontine infarcts where your reticular activating system is knocked off. Vertical gaze palsy. I can't resist showing you this, because I managed to get the video clip, and it is a beauty, even if I say it myself. This man had, I hope that's done it. One of the most useful things to test when you're doing eye movements is what we call saccades. And just to be sure, a saccade is a burst of conjugate eye movement. The best way to test is to have your patient here, and to do horizontal saccades, you say, the instruction is, look at the hand that's open. Look at this one, this one, this one, this one. If you do finger, thumb, it's too many words. Wiggle, wiggle, too much. Look at the hand that's open. This one, this one. So you get a double stimulus. You close this hand and you open this one. So you've got 2. And then you do vertical saccades. Look at the hand that's open. This one. Keep your head still, please. This one. Please keep your head still. Could you put your hand on again? Thank you. This one, this one. And you look at the saccade. These are half speed in every direction. And the arrow denotes when the eyes have arrived at their destination. And this person has slowing of vertical saccades. They take longer to go up and down than they take to go across. Both have been slowed to the same extent. I think it's particularly down gaze. The tick denotes when they've arrived. Do you get that? Easier when they're in front of you. So he had a vertical gaze palsy. Well, vertical gaze slowing. So, summarising those findings, how do I do it now? At the time, I'm cantering through this because it's for illustrative purposes, we put those together and said that must be thalamic, we put that must be ataxic. As a rule of thumb, signs that are ataxic-like are ipsilateral. There are 1 or 2 exceptions, but if you've got left-sided cerebellar signs, you've got a left-sided cerebellar lesion. There are some exceptions, but they're not worth having. What do people think of that as a sign of central nervous system disease? Gentleman in the far corner. If someone can do that, but they can't do that, do you go for that being central? I think that's very unusual. As a rule of thumb, central nervous system disease gets fine finger movements first. So someone can do that, and they can't do that. Something funny going there. Alarm bell, fractured humerus. Seen that? Dislocated shoulder, particularly after seizures and electric shocks. We've seen bilateral shoulder dislocation after seizures, sometimes in association with posterior fracture dislocations. So that rang bells, and I thought, I said, this can't be. This is something weird. This is a systemic disease. But sure enough, he had that infarct in his thalamus, and he had that infarct in his left cerebellum. So I accepted that the thalamus and the cerebellum were knocked off, but we then had to put it all together. And the doctor who was on at the time, Basil Ridder, who's now left, put this together at the bedside and said, this is all vertebral artery disease. And we subsequently, thanks to Owen Pickrell, put these pictures together. Posterior, anterior. Artery, vertebral artery in the vascular foramen, left, right. Full of blood. Let's imagine the left vertebral artery dissects. And dissection is invariably associated with an expansion of the vessel. If any of you need a way of explaining dissection, say to the patient, arteries are like two hose pipes, one within the other. Imagine one hose pipe within the other, then imagine a little tear in the inside hose pipe. Then the blood can go down the main lumen, or it can track between the two walls, and that starts to push the inner wall in, and suddenly you've got chaos. Big artery. As you know, you have one anterior spinal artery, two posterior spinal arteries. And the vertebral arteries in the neck give off these radicular branches to the anterior spinal artery. And here we have the dorsal root ganglion, and just in here, the anterior root. So when you expand your vertebral artery, you can either occlude the radicular artery, so you starve the motor root there of its blood, or the vertebral artery expanding just squashes the motor root. So, a perfect example of the damage the local donor vessel can do. Hasn't donated an embolus yet, it's just squashed stuff around it. If any of you need a way of remembering the blood supply to your posterior circulation, it's 4 to the thalamus, 3 to the cerebellum, 2 to the posterior spinal cord, and 1 to the anterior spinal cord. And we use the thalamus, and this is a direct product of the Wednesday afternoon stroke meetings, where we've all presented thalamic cases and gradually come to appreciate that I think these are the cases that have caught us all out, or made us just stop and think, hang on, I'm not confident here. So, vertebral arteries, basilar artery, posterior cerebral. Posterior communicating artery, which makes up the circle of Willis, sung to the tune of the Lion King, always, that's how you remember it. The circle of Willis. And we have, from the posterior circulation, 4 arteries to the thalamus, 1 to the anterior thalamus, which usually comes from the posterior communicator, and because the thalamus has 1,000 more corticothalamic connections than thalamocortical, it is really the central switchboard of your whole brain, because if you damage that, loads of input from the cortex is lost, you end up with speech and language problems and apathy. I should say, actually, the language is usually on the left, for obvious reasons. The neglect is usually on the right. Second artery to the lateral thalamus gives you sensory and motor deficits. The posterior thalamus gives you visual problems because of its connections. The paramedian thalamus, because it's just sitting above the midbrain, you get eye movement disorders, problems with vigilance, conscious level, and vertical gaze. It's worth remembering that in 30% of us, a common stem gives off branches that supply both sides of your thalamus. There is an anterior equivalent of that, which Yogesh Joshi taught us, and I'm just going to find the word, azygous pericallosal arteries. So one anterior cerebral artery gives off both anterior pericallosal arteries, so you end up with bilateral frontal lobe infarction with occlusion of one vessel. So, if you need to remember your posterior circulation, 4 to the thalamus, 3 to the cerebellum, 2 to the back of the cord, 1 to the anterior cord, and loads of perforators. By the way, I always share at this point the story of the medical student to whom I said, "Where does the spinothalamic tract run?" And she said to me, "From the spine to the thalamus. Where do you think?" I thought, I'm not going to react to that. And I managed somehow on the spot to say, actually, that's a very good point. Of course it runs from the spine to the thalamus. And then I said to the next student, "Where does the corticospinal tract run?" And they said, "From the cortex to the spine." And then I thought, hey, we're not making the most of all these words. Which bit of your cerebellum does the superior cerebellar artery supply? The superior bit. What about the anterior, inferior? The anterior. So you can now look at scans, and if you see that the posterior, inferior cerebellum is infarcted, you know that's a vertebral artery branch. Very useful. Okay. So, 2 more cases, just to make some points. So we've got more pain. Puts you off stroke. Don't like pain, but you're now tuned into the idea that it can be. And then he's got a hoarse voice, nausea and unsteadiness. And the main signs are that he's got a left Horner syndrome, a left 10th nerve palsy, and contralateral spinothalamic sensory loss. There are certain constellations of signs that immediately ring 1 or 2 bells. And for me, Horner's 10th and contralateral spinothalamic is basically lateral medullary syndrome. Well, what we should say is it's lateral medulla. And I've seen 4 things cause that. It's either vertebral artery or it's branched the pica. I've seen 1 patient with a cavanoma and 1 which was amazing with demyelination, and it just happened that the manifesting lesion was in the lateral medulla. But in practice, in casualty, lateral medullary syndrome, lateral medullary lesion is usually an infarct. Does anyone know the significance of that contralateral spinothalamic loss with the Horners, the lady with the specs on the back? Does that ring a bell for you? Because it's going to ring a loud bell after today, so if it doesn't ring a bell now, that's great. Next door. Does it ring a bell? Does that tell you something immediately? It tells me now, although I've only learnt this since doing this stroke work, that must be central. There's one exception to that, but if you've got a Horner's and contralateral spinothalamic sensory loss, the Horner's must be central. And the other useful thing about a Horner's syndrome is that it's always ipsilateralizing. So if you have a left Horner's, the lesion's on the left. If you can think of an exception to that, please email me. And to just remind you, and I always have to work this out from the top down, so you're starting from your hypothalamus, down through your midbrain into your medulla, and down to T1 in the spinal cord. Then the sympathetic fibres come out and synapse in the stellate ganglion, the fusion of the inferior cervical and superior thoracic. Then they go up the carotid artery through your cavernous sinus, superior orbital fissure to your eye. So a Horner syndrome tells you which side the lesion's on, doesn't tell you where on that pathway the lesion is. But as with all neurology, you look to see what else have they got, and that helps you lateralize. The only other thing that gives you ipsilateral Horner's and lower cranial nerve palsies is a carotid artery dissection. And we've seen lots of these on Wednesday afternoon. And the idea is that the carotid arteries in the carotid sheath, just under your skull base here, next door to it are your sympathetic chain, your 10th and your 12th. If your carotid artery suddenly expands due to dissection, it can knock off the sympathetic plexus and the lower cranial nerves. These are the lower cranial nerves outside the skull. They've exited the medulla, they've come out of the skull, they're on their way to things like the tongue and the larynx. But those patients don't have contralateral spinothalamic sensory loss. This patient had lateral medullary infarct, absent left vertebral artery. Day 4, he has a subarachnoid hemorrhage from his vertebral artery dissection and ends up with blood in his ventricles and hydrocephalus. And this was a case of vertebral artery dissection, lateral medullary syndrome presentation, complicated by subarachnoid hemorrhage and secondary hydrocephalus. To use the word StroKe is not to do that case justice. The word StroKe should be known as the Voldemort word of medicine, never to be said outside in public. Okay, and just to finish, this man who was presented the day before I was due to give this lecture, in casualty, the SpR in neurology was called to see this man who was unconscious, and these were his blood gases. And so he's acidotic, he's hypercapnic. No wonder he's asleep. And the reason, I showed you earlier, the way that one artery can supply both sides of the thalamus. He had a bilateral paramedian thalamic infarct, and he stopped breathing, basically. ITU ventilation. They do well if you treat them. So, to summarise the lecture, when you're thinking about the case, I should add, of course, that I think 80% of the time it is obvious what's happened. If someone in atrial fibrillation pitches up and they're dysphasic with the right hemiapresis and it came on suddenly whilst they were in Sainsbury's, it's probably a clot from their heart. So 80% of the time I think it is straightforward. But I think a significant minority put us through torture. And if you want to structure your thoughts about this, try this and then give me your feedback. When it comes to the donor vessel, I think most of the time the donor vessel doesn't actually contribute to the presentation. So unless someone's got heart failure or they're going so quickly that their rhythm is compensating their output, the fact that they're in atrial fibrillation doesn't really affect their presentation. They've just thrown off a clot. However, in the 2 cases I've shown, we were caught out by the mischief the donor vessel was causing. The vertebral artery dissection produced other things that made it difficult. The carotid dissection produced things that made it difficult. And the reason that carotid dissection is relevant is that if you get those lower cranial nerve palsies and then they throw a clot off, you've got this big problem. I'm just going to read that. The patient's in the scanner now, so I'll be on time to go and see them. There are other situations where the donor vessel dominates the clinical presentation. Aortic dissection. And in a way, that's the point where you say, well, yes, they are having a stroke, but the more important problem is the fact that they're dissecting their aorta. Then we have the effect of the infarcted brain on the clinical presentation. And 90% of the time, that's fine. It tells you what's going on. The fact that it respects an arterial boundary helps you think that it's a stroke. But remember that posterior circulation, I think, is where we all get caught out, and the thalamus is a chamber of secrets. Those were my points. Thank you for your attention. Feedback would be gratefully received at that email address.